Hi, you're welcome to today's lecture. My name is Dr. Isaboyin Henry. Today we'll be treating the topic relationship between the concept of primary health care, universal health coverage, and sustainable development goals. We'll be seeing it as a continuum of health and development. These are the contents that we'll be treating overall on this topic. Number one, we'll be seeing introduction to the primary health care, what the universal health coverage means, and the sustainable development goals. Number two, we'll be looking at the conceptual relationships between the PHC, UHC, and the sustainable development goals. Number three, we'll be looking at the evidence and case studies. Number four, strategic approaches. We'll be looking at how to make the primary health care and the goals work together harmoniously. Number five, we'll be looking at the summary and the key takeaways. And finally, we'll look at some reflections or some questions that could help us reflect on all that we have learned. Under the introduction to primary health care, UHC and SDGs, some other subtopics we'll be looking at include what is primary health care, what is the SDGs or what are the SDGs, why is it important in relation as a concept to this PHC, and we'll also see why link PHC, UHC and the SDGs. Are there any link? And if there are, why is there the need to link them together? Number two, we'll be looking at conceptual relationships. That is the PHC, UHC, and the SDGs. Under it, we'll be looking at the PHC, what exactly is the core aspect of it, and what are the extensions as a model. And under it again, we'll be looking at the UHC as the bridge. We'll also be looking at the PHC and UHC inside the SDG ecosystem. And then we will visualize a model that tends to bring them together and how much they function. Under number three, which is the evidence and case studies, we'll be looking at empirical evidence, how practically this has worked and what it has looked like. We'll also be looking at country regional cases from different aspects of the world. And then we'll look at some of the constraints that they experienced, and then some trade-offs, some challenges that has been experienced in the past. And that will also give us a limelight, to give us a direction as to what is expected and how to be able to overcome them. Under number four, which is strategic approaches, in how to make the PHC and the SDG work, we'll be looking at how to strengthen the PHC system, how this PHC system in form of multisectoral action, function on a larger scale. We'll also look at the community and citizen empowerment, how we get the community involved, why we get them involved, and of what purpose and to what outcome do we expect. We'll also be looking at financing and resources, protecting the PHC in national budgets, because the PHC, like we will see during the lecture, what it stands on, what it depends on, how it influences, and how it is also influenced, and where financial, aspect comes into it, and resources as well. The national budget, this must really protect, the PHC when you have this on ground, because the national budget plays a key role in distribution to a lot of things. And so PHC has to be protected, because if it is protected, then many other aspects will be taken care of. And the last one under number four is the monitoring and the feedback. We'll be seeing how the monitoring is done, what the feedback are, and so on. Now let's see the learning objectives. Number one, we'll be defining the PHC clearly. Number two, we'll break down the SDGs. Number three, we will see the connections between PHCs and UHCs and SDGs. All this we will be looking at, including we'll look at how to think policy and practice, within the health system. Now, if we want to start, let's start with the PHC clearly, because in defining the PHC clearly, you will understand what primary health care is. You will understand the principle behind it, like equity and community participation. And also, you will understand its main building blocks, just like WHO in 2018 did put it. Under the breakdown of the SDGs, you will learn how the Sustainable Development Goals are structured, with special focus on the SDG 3, which is good health and well-being, and the specific health targets under it, and that as explained by the United Nations in 2015. We will also see the connections between PHC, UHC, and the SDGs. Here you will be able to explain how PHC universal health coverage and the SDGs are not separate. They work in continuum, but parts of one connected to a system, and they are in form of a continuum. The other is connected to the other, and the other is affected by the other, and the other is also influenced by the other, and so it's a continuum. We also see map real examples. Here you will learn how the everyday work of PHC, such like immunization, maternal care, and health promotion does work, and how it directly fits into the UHC outcomes and helps us achieve the SDG target, just like the WHO in 2020 did put it. We also see how to spot the challenges and opportunities. Here you will be able to identify the synergies where they support each other. You will also see the tension where they clash, and then you will see the trade-offs where we must choose the priorities when trying to align the PHC and the UHC and the SDG strategies. Finally, think policy and practice. Here, we will be equipped to suggest practical strategies to policy levers in order to be able to make sure that the PHC, the UHC, and the SDGs are better aligned in real-world health systems. So, by the end of this lecture, you won't just know the definitions. You will be able to think like a systems leader, and you'll be able to connect the PHC at the community level, the UHC at the system level, and the SDG at the global level. So let's continue. We will now start with the introduction to PHC and UHC and the SDGs. So the first part we'll be looking at is what is primary health care, that is the PHC. Apart from that, we'll also look at what about the Sustainable Development Goals, the SDGs. Let's take that too first of all. So what is primary health care? That's the PHC. We'll start simple. We don't need to make it complex using big grammars. The primary health care is not just about the first clinic you visit, like everybody, a lot of people tend to see it. It's a whole way of organizing health systems so that services are close to the people and are connected to their daily lives. The World Health Organization actually defines PHC as a whole of society approach to health that ensures the highest possible level of health and well-being, ensuring that it is fairly distributed by focusing on people's needs from health promotion and prevention to treatment, rehabilitation, and palliative care, as close as possible to people's everyday environment. That's the definition of the PHC according to the WHO in 2022. I'll take it again. It's a whole of society approach to health that ensures that the highest possible level of health and well-being fairly distributed by focusing on people's needs, from health promotion and prevention to treatment, rehabilitation, and palliative care, as close as possible to people's everyday environment. So, PHC is broad. It is preventive, promotive, curative, rehabilitative, and palliative. It doesn't stop at hospitals. It connects also to the schools, water, housing, and the communities. Now, there are three main components of the PHC. According to WHO, PHC stands on three interconnected pillars. And what are these pillars? Number one, comprehensive services. Number two, multi-sectoral action. And number three, empowering people and communities. Now, under the first one, which is the comprehensive services, remember we are still talking about what is the primary health care, what's the primary health care? That's the PHC. Now, under the comprehensive services, is like I said in the beginning, it's not just about the first contact, but everything from health promotion to rehabilitation and palliative care is what you find in the primary health care. Now, when we say it is multi-sectoral action, we simply mean that it is tackling social determinants, those things that make social life wholesome, conducive, comfortable, and healthy, such like water, sanitation, education, housing, and environment. Number three, we also see that empowering people and communities simply means making sure that individuals can take part in their health decisions. They can take part in their self-care and community participations. Having said this about the primary health care, at its heart, PHC is built on equity, justice, solidarity, and participation. And they believe that health is a human right and no one should be excluded because of poverty, no one should be excluded because of distance or social status. Let's look at the number three, which is core principles of PHC. The core principles of PHC. Now, when we say the core principles of PHC, we are referring to the Alma Ata Declaration of 1978. So let's break them down, using the classical principles of the PHC. Number one, you have the universal access as enshrined under the Alma Ata Declaration of 1978. So one of the core principles of PHC is that healthcare should reach everyone, no matter their income or where they live. Another core principle is the community involvement. Number two, community involvement. We're talking about the core principles now of PHC. Now, people must help plan and manage health initiatives. Number three is health promotion, which is also part of the core principles of PHC. It simply means that don't just treat illness, but invest in the prevention of that same illness, invest in education, and also healthier living. Number four core principles of the PHC is the appropriate technology. That is the use of tools and methods that are affordable, sustainable, and culturally acceptable. And number five of the core principles of PHC is the intersectoral collaboration. because health depends on many other sectors: water, agriculture, sanitation, education, transport. So these principles till date still guide the PHC today. So let me repeat the principles again. The core principles of the PHC: number 1, universal access; number 2, community involvement; number 3, health promotion; number 4, appropriate technology; and number 5, intersectoral collaboration. Now let us see the functions of the PHC in practice. The functions of PHC in practice. How does the PHC actually work on a day-to-day basis? Number 1, it provides service provision. Number 2, it has its public health functions. Number 3, it has its multi-sectoral work. And number 4, it empowers the community. And then number 5, it provides referral links. So let me just give a little explanation to each of them. What the PHC does on a day-to-day. I said number 1, service provision. And here when you go to the PHCs, they provide immunization, maternal and child care, chronic disease management, and then you also have basic curative and palliative care. You find all this in the PHC centers. Number 2, I said they have a public health function. What are these functions? They provide surveillance, outbreak control, environmental health, and health campaigns. You also have the multi-sectoral work. Why is it multi-sectoral? We are talking about in a situation where they join hands, the PHC joining hands with the housing, with sanitation, with transport, and agriculture. So the PHC don't just stay alone. It works in conjunction and collaboration with other sectors. Number 4, you have community empowerment. You have health literacy, participatory planning, accountability, and support for community health workers. And then number 5, you have the referral links. Under the referral links, this is where people are connected to higher level care when it is needed. And so you see that the PHC is not just a clinic. It's not just a clinic. It's the foundation of an entire health system. And finally, let's look at number 5, under what the primary health care is. We're taking it from the Alma Ata of 1978 to the Astana of 2018. Now, these are both declarations. If you look at the Alma Ata Declaration of 1978, it gave us the vision of health for all. In 2018, the Asthma Declaration reaffirmed that PHC's role for today's world. And when it affirmed the PHC's role for today's world, it gave us the 3 big functions that the PHC should fulfill. And the 3 big functions include, number 1, to deliver comprehensive services. And number 2, to act across sectors on health determinants. And number 3, to empower communities and citizens. I repeat, of the 3 big functions, number 1 is to deliver comprehensive services. Number 2 is to empower communities and citizens. And number 3 is to act across sectors on health determinants. Now, what are the key takeaways from all that we have said concerning the definition of the PHC? It's not just about clinics or doctors. Now we know. It's a people-centered, justice-driven approach to health. Health for all. It's one that combines both services, social action, and community empowerment. So it remains the cornerstone of a resilient, equitable health systems. And this is according to the WHO. Now let's look at the Sustainable Development Goals. The Sustainable Development Goals. What are the Sustainable Development Goals? Particularly the SDG 3. How does the SDG 3 or SDG agenda incorporate health? Now, to answer this and to help you have a better understanding, we will look at a quick intro to the SDGs. Let's understand, what are these SDGs? You know, in 2015, the United Nations actually launched the 2030 Agenda for Sustainable Development, and it gave the world 17 goals and called them the Sustainable Development Goals, which is to be achieved by 2030. Now, here's the key thing. These goals are interconnected. Progress in one affects the other. For example, better education leads to better health. Better health will help reduce poverty. And reducing poverty will improve health again. So it's like a web. Everything is linked. Like I just said, as an example, better education will lead to better health. And better health will help reduce poverty. And reducing poverty will improve health again. So like I said, it's a web. Everything is linked from goal 1 to goal 17. And so health plays a dual role here. Number 1, it's an outcome because we want people to be healthy. And number 2, it is also a driver. Why is it a driver? Because good health boosts education. Good health boosts gender equality, and it improves economic growth. Now let's look at the SDG 3 proper. What is this SDG 3? Simply put, the health goal. Now, the main health goal is SDG 3. Of all of them, the main health goal is the SDG 3. It is broken down into 13 targets and 28 indicators. I repeat, when you hear the SDG 3, it is broken down into 13 targets and 28 indicators. And this covers almost all areas of health. Now, I'll take my time to talk about some key ones. Let me start with number 1, maternal and child health, or just to list it so that you can take down your notes. Maternal and child health is number 1 of these 13 targets. I just want to take a few that are key. Number 2 is infectious diseases. Number 3, non-communicable diseases. Number 4, universal health coverage. Number 5, other targets which include reproductive health, tackling substance abuse, environmental health, and access to medicines and emergency preparedness. Now let's take them one by one. Under the SDGs, now we are looking at the 13 targets under the SDG 3. Like I said, the SDG 3 was broken into 13 targets and 28 indicators. So I took just a few key ones that I feel is very, very key that you must understand under this topic. So the first one is maternal and child death. It is key because it reduced maternal deaths and under 5 mortality. And that's target 3.1 and 3.2. It reduced maternal deaths and under 5 mortality rates. Reduce maternity deaths, and under 5 mortality. And these targets are 3.1 and 3.2. Now, under the infectious disease, it ends pandemics. Pandemics of HIV, AIDS, pandemics of TB. They also have malaria and those neglected tropical diseases. And this is target 3.3. Now, under the non-communicable diseases, remember we are looking at the key ones under this 13 target. Non-communicable diseases. Why is it key? Because it reduces premature deaths from things like heart disease, diabetes, cancer. This is target 3.4. You now have the universal health coverage. Under these key areas amongst the 13 targets, you have universal health coverage. Why is it key? Because it ensures that people have access to services without financial hardship. That is target 3.8. And like I said before, there are other targets which include reproductive health, tackling of substance abuse and environmental health, access to medicines, and emergency preparedness. Now I want you to notice how the universal health care, that is target 3.8, is central in this discussion. I want you to notice it because it links the SDG agenda of all the targets we have mentioned. Out of the 13 targets and 28 indicators, the UHC links the SDG agenda to health system reform. And how does it do that? By showing that health isn't just about hospitals, but about fair financing and system-wide coverage. Now let us see health across other SDGs. Other SDGs, let us see the influence of the health, there. Remember I told you that there are 17 SDG goals. And we have seen under the SDG 3, we have seen the 13 targets, that it has 13 targets and 28 indicators. And I've listed about 5 key ones to you. And now we are particular about the target 3.8, which is the universal health coverage. And we have said that it links the SDG agenda to health system reform. And that shows that health isn't just about hospitals, but about the issue of fair financing and system-wide coverage. Now let's see, like I said, health across other SDGs. Now here's what it gets. This is where it gets interesting. Even though the SDG 3 is the health goal, proper, health is woven through many other SDGs. Even though we know that the SDG 3 is the health goal, but if you look at it deeply, health is woven through many other SDGs. For example, when you see the SDG 1, which is no poverty, we see that illness can drive families into poverty through medical bills. Poverty also blocks access to care. So you see, SDG 1, no poverty. You see its relationship to health. Number 2, SDG 2, which is zero hunger. Zero hunger. Here you see that malnutrition weakens immunity and it worsens one's health. So nutrition programs are part of the PHC so that the immunity can be boosted and health will not be worsened. You see the relationship between SDG 2 and health? Now let's look at SDG 4, quality education. Quality education. Now for the SDG 4, you see that education improves health literacy and use of preventive services. When people are educated, they become literate. They understand the importance of health and why it is important to use preventive services. Now for the SDG 5, we are talking about gender equality. Gender gaps affect reproductive health, autonomy, and access to care. Now, these gender gaps, you would wonder, as SDG 5, what is its business with health? But it affects the reproductive health of both male and female. It affects the autonomy, decision to take their right to take health decisions, and also to access care wherever they find themselves. For the SDG 6, which is clean water and sanitation. SDG 6, clean water and sanitation. Here you see that safe water and hygiene are critical for preventing disease. Imagine somebody being treated and is not taking water, or is taking water but the water is not safe. You know what the repercussion will be. So safe water has a very strong link with health, and hygiene has a very strong link also with health. Together they prevent disease. SDG 10, which is reduced inequalities. Reduced inequalities, that's the SDG 10. How does it relate to health? When PHC is designed at any point in time, the essence of that design is to reduce health inequality. Let everybody have access, female, male, old, young, babies, everyone. The SDG 11, which is called sustainable cities. There we are talking about urban planning, and to be able to control pollution and to ensure that we have safe housing. All these things shape health. If there's a bad urban planning and pollution is not being controlled within the city, you know what that will tell on the health of the citizens or the people living in that community. So you see, Sustainable Development Goal 11, sustainable cities, has a very strong link with health. Now look at the SDG 13, which is climate action. SDG 13, climate action. Climate change drives new health risk, because when there is a climate change, there is also some evident change within the environment, and this can predispose persons to health risk, such like heat stress, such like flooding, and even vector-borne diseases. So you see that climate action, when studied, you can be able to now know or understand how to mitigate the resultant effect to health. So we can go on and on. Yeah, we could go on and on, because all the SDG goals, they have a clear relationship with health. However, health is literally woven into the fabric of the SDGs. Without health, other goals will struggle. And without other goals, health will struggle. So you see that? Without health, other goals will struggle. And without the other goals, health also will struggle. So here you see that health and the goals work together, so that health does not struggle and the goals themselves perform well, or they are achieved. Well, to conclude this part, before we move to number 3, to conclude the SDG goal, I like to state this, that health is the very heartbeat of the SDGs. The very heartbeat of the SDGs. It is both a goal on its own, that is the SDG 3. It's both a goal on its own and the fuel that drives progress in education, poverty reduction, gender equality, and even climate action. So, health is the very heartbeat of the SDGs. So why do we have the SDGs? Essentially for health. And on its own, it fuels, the progress in education, poverty reduction, gender equality. Let's now move to the third one. Why link the PHC and the UHC and the SDGs? Why? What's the importance of discussing it? How are they connected as a system? When we talk about the primary health care, universal health coverage, and the sustainable development goals, many times they are taught like three separate topics. And you must have seen the topic and say, PHC, UHC, SDG. Are we going to learn all these ones in one? No. You shouldn't see them as three separate topics. Let's see it this way. Just think about it this way. PHC looks like just the basic care. See it this way also. UHC, universal health coverage, looks like only financing and insurance. Then the third part, SDGs, look like big global targets. Let me take it again. We are looking at the link between the PHC, UHC, and the SDGs as a connected system, not in silos, not in separate, topics. The PHC looks like just basic care. UHC looks like only financing and insurance. And SDGs look like big global targets. But if we leave them separate, you may miss the bigger picture. If we say let's just treat PHC separately, UHC separately, there's a bigger picture that you will miss. And the reality is this. In the real world health system, these three are deeply connected together. Again, let's think of it this way. Let's see PHC as the foundation. Yes, as the foundation. It's not optional. It is the foundation. It is the entry point that makes healthcare fair and accessible to everyone. Now, UHC, that is the universal health coverage, is the structure built on PHC. Without a strong primary health care, you cannot achieve true universal coverage. If the primary health care is not solid, if what makes health care fair and accessible is not solid, then universal health coverage for everyone universally will not be in place. In fact, it will not achieve its true goal. Now, the SDGs, especially the SDG 3, that is the good health and well-being, you can see that as the roof. They can only stand when PHC and UHC are in place. So see the PHC as foundation. On top of the PHC, you have the UHC, that is universal health coverage. And when the PHC is solid, we can now achieve true universal health coverage. Now, when universal health coverage is truly achieved, then you see that there will be good health and well-being for all, where the SDG is now the roof of the structure, UHC, that is built on the foundation, PHC. I'm sure you got that illustration. Why linking them? Why do they matter? Number one, it avoids fragmentation, so that as a student, as a future public health professional, you would see these three as a whole system, not disconnected pieces. And number two, to encourage critical thinking, you start asking the question, if we invest too much in tertiary hospitals, what happens to the PHCs, the primary healthcare centers? Or how does education, that is the SDG 4, how does it influence health outcomes? You begin to ask solid questions. Critical thinking comes in. Number three, it will promote system alignment. You suddenly realize interventions must connect across all levels, not just intervening in one area and abandoning the other area, from the community clinic all the way to national policies. Number four, build system thinking skills. As a professional in the making, you begin to see feedback loops, like how strong PHC will boost economic productivity, which in the end will reduce poverty, and in the end it will turn or improve health again. Now look at the continuum this way. Again, another illustration. PHC gives the principles. And what are the principles? Fair access to healthcare, financial protection for all to be able to access healthcare, and service coverage to be able to get all the services as obtainable in the primary healthcare. Now, the UHC will then come in to measure whether the system, that is the PHC, is actually delivering this fairly to everyone. So while the primary health care is providing these principles of fair access, financial protection for all, and service coverage for everyone, the UHC comes in to say, let us look at it. Let's measure whether the system, the PHC system, is actually delivering this to everyone on a fair ground, on an equal ground. While the SDG will then show the broader picture. I haven't seen the PHC, UHC coming in to now check whether it is delivering it as planned. You now see the SDGs now showing how health connects with poverty, education, gender equality, water, sanitation, and climate change. All these things, when they are in place, they help the PHC to function properly. So you see the connection. PHC providing the principles, UHC ensuring that the PHC is doing it properly and providing all that it takes, and the SDG linking it, connecting it with other aspects of social life, social determinants. So instead of thinking of them separately, you should see it as a chain. The PHC leading to the UHC, that is universal health coverage, and then to the SDGs, and back again to the stronger PHCs. Because when that link PHC to UHC to SDGs, if it's constant, solid, it will come back to give rise to a stronger PHC. Now, we'll see the key takeaway for students, for young, or let me call it future professionals in public health. What are the takeaways for future leaders in public health? When you see the PHC, UHC, and the SDGs as a continuum, you will start to design better. You will start to design fairer and more sustainable health systems. Yes. You also will avoid trade-offs, like spending all the money on advanced hospitals while neglecting community-level primary health care. In fact, PHC is the engine. UHC is the vehicle. And the SDGs are the destination. Without linking them, the journey will break down. Because PHC is the engine, the vehicle is the UHC, and the destination is the SDG. So, Imagine taking away the engine from the vehicle. That vehicle cannot get to the destination. So the vehicle needs, the UHC needs the PHC to be able to get to the SDG. The journey must not in any way be tampered so that it can be a smooth one. Let's move to the next one, which is number 4. Having discussed this introduction to the PHC and SDGs, I believe that you have learned a lot and what should be the outcome. By now, you should be able to define primary health care, its principles, and the core components. You should be able to explain the architecture of these SDGs and the specific targets under SDG 3, which is the good health and well-being. I've talked about it. You should be able to describe how the PHC, the universal health coverage, and SDGs are interconnected as a continuum rather than separate domains. And I'm sure that by now you should be able to map a concrete example of how functions of the PHC feed into the UHC outcomes and contribute to the SDG targets. You should also be able to identify the synergies, the tensions, and trade-offs in aligning both the PHC, the UHC, and the SDG strategies. And you should also be able to propose strategies or policy levers so that it can better strengthen alignment among the PHC, UHC, and the SDGs in real-world setting. So these are the 17 goals. And we have just seen number 3, good health and well-being. Ensure healthy lives and promote well-being for all at all ages. We move to the second aspect, which is conceptual relationships between the PHC, UHC, and SDGs. Now, in these parts of our lecture, I want you to see how primary health care PHC, universal health coverage UHC, and the sustainable development goals are not 3 separate topics. I've tried discussing it. I want to also dig deeper into it now. They are actually pieces of the same puzzle. So think of them as a health development continuum. Once you understand these connections, you will see how health systems really work in the real world. We see the first part, the PHC, both core plus extension. Want to see the PHC model? The PHC model has its aspects. Sincerely, it has its core, and there are other extensions. So as a PHC model, we want to see what it means. Now, under the core, that is now you can write down, we want to see the first aspect, the PHC core function. The core function of the PHC. And this is just talking about the essential services that every PHC system must, I use the word must provide. First contact, PHC is the entry point. When people are sick or need care, the first stop should be the PHC, the primary health care centers. Not running straight to a specialist hospital or a general hospital. Number 2, as part of its core function is promotive services. Health promotion activities like nutrition, advice, hygiene, education, exercise campaigns, and vaccination awareness. These are key functions It carries out a promotive service. And this will prevent people from coming down with illness, a kind of prevention. And that leads us to the third one, which is preventive services. Things like immunization, screenings, antenatal care, and prevention for both infectious and non-communicable diseases. It also has another major function, curative services. What does it mean? Curative services simply tells us that it provides basic diagnosis and treatment of common illnesses like malaria, diarrhea, or hypertension management at the community level. Another key function is the rehabilitative care, helping people regain function after illness or injury. For example, post-stroke physiotherapy. When people are ill and they have been treated and they want to help them regain functions of their parts of the body. For example, like I told you, post-stroke physiotherapy, when somebody has stroke. So this is one of the key functions, core of the PHC. And finally, palliative care, supporting patients who need relief from pain or end-of-life care, close to their homes and families. Patients are supported. Some of them, maybe they have cancer, always in pain. Or some of them, end-of-life care, they just have a short number of days remaining for them to live. You don't just abandon them. The PHC provides palliative care for them. And they are close to their homes and their families. The PHC is the front door of the health system in any nation. It covers everything from prevention to health promotion, all the way to palliative care. Let's see the second aspect, which is the extension. That is PHC's extended roles. Like I said, PHC is not just about clinic and services. It also has some bigger extended roles that connect health to society. You can write that number 1, tackling social determinants. Tackling social determinants. Yeah, PHC cannot succeed in isolation. It must connect with water, sanitation, housing, nutrition, education, agriculture, transport, and even social protection. Health is affected by all this that I've mentioned. Number 2, extended role of the PHC is community empowerment. Apart from tackling social determinants, you also have its role in community empowerment. You see, the PHC is not done to. It's not done to people. It's done with people. It is established with people. It's not just like a gift to people and then they can use it and dump it and keep it when it's expired or throw it away. It is with the people. Communities participate in the planning of the PHC. They participate in monitoring the PHC, even in decision making. They gain health literacy, self-care skills, and stronger networks. The third role is the whole of society approach. The whole of society approach. WHOLE, of society approach. What it simply means is that PHC recognizes that health is everyone's business. It recognizes that health is everyone's business. Beyond that, not just the Ministry of Health or other ministries or civil society or private sector and communities. No, but all of them that I've mentioned, they all play a role. So it's not a matter of, okay, this one plays one role. No. Everybody, not only the Ministry of Health, in conjunction with civil society, private sector, like I've said, both the community, they all play important role. And therefore, at the heart of this equity, everybody coming together, putting their equal, strength and knowledge, skill together, they make sure that even the poorest and the most disadvantaged are not left behind. So, in that community, even the poorest can go to the PHC to get health coverage, to enjoy health services. They are not left behind. So, let's see the bigger picture under the PHC core plus extension model. Imagine that PHC is the hub at the center, providing core services. But from this hub, there are different spokes like arrow that extend outwards into community, into other sectors, into the governance, into the wider health system. So PHC having a way to touch the community, PHC touching other sectors in the community, touching the governance and also the wider health system. That's why we say that PHC is not just a service package. It's a system orientation. It's how the whole health system is designed to connect with universal health coverage and eventually will drive the progress or will drive progress in achieving the SDGs. Let's move to the second aspect, which is universal health coverage as the bridge. Universal health coverage as the bridge. So PHC is the core with other extended role. Now UHC is coming in as the bridge because it is universal health coverage. From the local primary, the universal comes in now and says, let me bridge you, let me connect you to the world. So let's talk about the universal health coverage now. I want you to think of the UHC as the bridge between PHC and the bigger development agenda, which is what? The SDGs. And why should you think like that? Because while PHC gives us the services, UHC gives us the financing, UHC gives us the structure and the guarantees that make those services work for everyone. So, what is the universal health coverage? According to the World Health Organization, the UHC simply means everyone gets the health services they need without suffering financial hardship. Everyone gets the health services they need without suffering financial hardship. Simple. That's what the WHO defines UHC as. But it has two key dimensions. It has two key dimensions. Number one, service coverage. Number two, finance protection. What does it mean when we say it has service coverage as one of its dimensions? That service coverage simply means making sure that people actually have access to both the essential quality health services. The financial protection simply means making sure that people don't fall into poverty because of out-of-pocket health spending. So when people now get sick and because they have to pay out of their pockets, they get ruined. They withdraw all the money from the bank account. And this is what the UHC wants to prevent. That people don't fall into poverty because they have a sick loved one. That's why the SDGs target 3.8 says achieve universal health coverage including financial risk protection, access to essential services, and access to safe, effective, and affordable medicines and vaccines for all. I repeat, the target 3.8 of the SDG says achieve universal health coverage, including financial risk protection, access to essential services, and access to safe, effective, and affordable medicines and vaccines for all. Now, how does the UHC and the PHC work together? How do they work together? PHC is the engine, simple. The primary health care is the engine because it delivers promotive, preventive, curative, and palliative care. It provides the principles. While the UHC, the universal health coverage, is the shell around that engine that provides the financing for that engine to work. It provides the insurance for the engine, that's the PHC, to work, and it guarantees the system so that the engine runs fairly and sustainably, so that the engine does not break down. So imagine an engine that is not being serviced because there is no finance. What will happen to that engine? The engine will eventually break down. But when the finance keeps coming from the universal health coverage, the primary health centers, the primary health care, the engine will be running fine. In fact, WHO actually notes that 90% of essential universal health coverage interventions can be delivered through the PHC. And if we scale the PHC up properly, we can achieve about 75% of the health gains expected from the SDGs. And this is truly massive. If the right investment, if the proper scale-up is given to the PHC, it will bring about a great breakthrough such that 75% will be achieved. Those health gains that are expected from the SDGs will be long achieved if the PHC is properly serviced. Now, how does the UHC support PHC in terms of operation? In terms of operation, how does it support the PHC? We've been hearing universal health coverage. We've heard that it provides the finance, it provides the protection, it provides. How does it now support it in practice and in operation? There are 5 ways. Number 1, it makes service affordable. Number 2, it defines a service package. Number 3, it strengthens health system. Number 4, it improves accountability. And number 5, it provides incentives or incentivizes better care. Let's look at it one by one. When we say make service affordable, that is through public funding, the health insurances that we see today, the risk pooling, people can now use PHC without going broke. The question is, do you have any health insurance? Have you registered yourself and the family and your family? Number 2, I said it defines a service package. Universal health coverage sets an essential benefit package that PHC delivers, so priorities are clear and realistic. When there is an essential benefits package that is provided by the UHC, the PHC is expected to deliver it. And when it's doing that, it does that by priorities. And these priorities will be clear and they are realistic. It's not going to be vague. We also see number 3, the strengthens health system. And how does it do that? Through UHC investment. This investment, they will build the backbone. As people invest in the universal health coverage, it builds the backbone of the PHC. Health worker are paid their salary and medicines are provided. The data systems are constantly serviced and maintained, and you have the governance in place. How does it improve accountability, which is number 4? The UHC requires countries to track what we call coverage. You have to track it. Is this PHC everywhere in the country? Is it reaching out to the most remote areas? We have to check equity. Is it only serving the rich? Is it also taking care of the poor? You have to also check the issue of cost protection. I hope people don't go broke once they visit the PHC. This way, you help the PHC get better because it has an improved accountability. And number 5, incentivizes better care. Payment models can reward PHC providers for quality, for prevention, and continuity of care, not just for treatment illness. When people do well, you pay them, and the payment is such that it's encouraging. They are willing to make more sacrifices, even work overtime, deliver quality services for everyone. So what's the takeaway? What is the takeaway here? The takeaway is that PHC is the engine and the UHC is the governance and financing shell that makes sure that the engine runs smoothly, equitably, and for everyone. So you can see how the UHC is now the bridge. Very important. That's why we say UHC operationalizes the PHC and it connects it directly to the SDGs. Let's see the third one. PHC and the UHC in the SDG ecosystem. This time, I'd like us to zoom out a little and let's see how the primary health care and the universal health coverage fit into the big picture of the SDGs. We have seen the direct relationship between the PHC and the UHC, but now I want to see how the both of them fit into the big picture of the SDGs. Now we'll look at the SDG 3 and the UHC. I told you, the UHC target 3.8 is the core, health for everyone. And we want to see how the both of them, how they fit into the SDGs. Now, the main health goal, like I've said before now, is the SDG 3. Of all the SDGs, that's the one for health, is the SDG 3, which is good health and well-being, and it covers things like safe motherhood and reducing childbirth. It also covers fighting infectious disease like HIV, tuberculosis, malaria. It also covers tackling non-communicable diseases, that is diabetes, heart diseases, cancers. It also promotes mental health and reducing substance abuse. And I also remember saying that it prepares for and responds to health emergencies, because all these things, when they're in place, let the health emergency come, the primary health center is very much ready to tackle it. Within the SDG 3, there's a very special target, which is the target 3.8, universal health coverage. That means everyone should, number 1, get the health services that they need. Number 2, services should be of good quality. And number 3, no one should go bankrupt paying for care. Now, the world actually tracks UHC progress using 2 key indicators. The UHC project, that is the universal health coverage, the progress is tracked by using 2 indicators according to the WHO. Number 1 is called the service coverage index. The service coverage index. And number 2, financial protection. When we say the service coverage index, we are simply saying, are people accessing the essential services? Do they even know about it? Are they aware? Are they aware of it? Do they have the knowledge that this is provided in the primary health care. Number 2, we talked about it as the second key indicator, which is financial protection. Are people protected from catastrophic health spending? Are they protected? So in a summary, the SDG 3 sets the big health agenda, and the universal health coverage target 3.8 explains how health systems through the PHC should deliver it. Again, the SDG 3 sets the big health agenda, and then the universal health coverage, which is target 3.8, comes in to explain how health systems through the PHC should deliver it. Let's look at the PHC through the universal health coverage as the vehicle for the SDG 3. Remember, we said the PHC is the engine, the UHC is the vehicle, and the destination is this SDG. So let's see how PHC through the universal health coverage as a vehicle, moves to the SDG 3. Number 1, PHC delivers most essential services. What are these services? Maternal health, child health, infectious disease control, non-communicable disease management. All of these are rooted in the primary health care. Number 2 is PHC seen as the engine. And when we say the PHC is the engine, we are simply saying that global experts call PHC the engine that powers the universal health coverage and the health-related SDGs. And number 3, we are seeing, remember we are talking about how PHC through the UHC vehicle moves to the SDG 3 or achieves the SDG 3. So number 3, under it we have seen number 1, that PHC delivers most essential services. Number 2, we have seen that PHC is the engine. Number 3, we are seeing that global consensus. It is a global consensus because the Astana Declaration the Astana Declaration has in a way already reaffirmed it again and again that the PHC is at the heart of achieving the universal health coverage and the SDG 3. So it's a global consensus. So now tell me, if PHC delivers most essential services, PHC is the engine, and it exists as a global consensus, therefore, PHC, supported by the UHC, remains the main vehicle driving towards SDG 3, which is good health and well-being. Again, let's still see this connection of the PHC, UHC, and other SDGs. Health isn't just about clinics and hospitals. Remember, I've always said that. Let that stick in. It is deeply connected to other goals. For example, SDG 6, clean water and sanitation. If there's no clean water, there will be more diarrhea disease. And that will lead to harder work for the PHC. Remember the SDG 4, quality education. That will lead to better education, because better education will give you better health literacy and stronger use of the PHC. People will now learn to use the PHC because they have the knowledge. You have the SDG 5, which is gender equality, women's empowerment. When you have it in place, it will lead to better access to reproductive and child health services. So you can't joke with the empowerment of the women. Look at the SDG 1, no poverty. You know that poverty traps families in illness. They can't buy drug if they are poor. While good health will help lift people out of poverty, when they are healthy, they will go and work and make money. The SDG 13 talks about climate action. This climate change brings floods, heat waves, new disease patterns that PHC must be able to adapt to, so that when it comes, they have what it takes to surmount that challenge. In other words, PHC depends on other SDGs, and the other SDGs depend on the PHC to be able to function and to be able to succeed. So it's a two-way relationship. When PHC and UHC are strong, people get healthier. Productivity goes up. Poverty goes down. Education improves. Environment will get better. And all of this strengthens the PHC even more. But there is a negative cycle in all of this. Hold on, please. I'll get back to you.
Do you want to join us? You are in class.
Okay, I was talking about the PHC, the negative cycle. If poverty stays high, schools will be weak, and there will be no clean water. You see that now? There will be no clean water. And when there is no clean water, PHC will struggle, and people will get sicker, and productivity will fall. And when productivity falls, other SDGs also fail. That's the problem. Just like you have a positive cycle, you also have a negative cycle. If poverty is allowed to keep growing, soaring higher, the schools are weak, or there's no clean water, there will be problem. Real problem. The PHC will struggle. You know, when PHC struggle, people will get sick. No doctor, no nurse, no scientist, no pharmacist. Nobody is there. Productivity will fall because everybody is sick in the community. Nobody's going to work. There's a pandemic. And the other SDGs will fail. But there are trade-offs and tensions. And what are the trade-offs and tensions? If government spend too much on big hospitals and forget about PHC, most people won't have access to basic health. That's what will happen. If government spend too much on big hospitals and forget about PHC, most people won't have access to basic care. And that increases inequality and slows down the SDG progress. It will slow it down. And therefore, in conclusion of this aspect of the PHC and UHC, the relationship in the SDG ecosystem, I'd like you to think of PHC, UHC, and SDGs as gears in one machine. If one gear stops to work, the whole system will slow down. But when all the gears, gear 1, gear 2, gear 3, gear 4, gear 5, or number of gears, if all the gears move together, the system will run smoothly, and health and development goals will be achieved. So that is that. So I have shown you the visual model, and I've explained that to you as it works. And that is the positive cycle, the negative cycle, the trade-off. Government should not spend too much on big hospitals and forget the PHC, because most people won't have access to basic care when the PHC is abandoned. So that is that. Let's see. This is the PHC core function that I told you. Services. First contact access. The core function. Promotive services. Preventive services. Rehabilitative care. Palliative care. And curative services. And this is how the UHC supports the PHC operation. It makes services affordable, defines a clear service package, and builds stronger health systems, monitoring and accountability, and incentivizes the PHC, sort of provide incentives for better PHC. You can also see the PHC is the engine, and the UHC, that is the governance, financing shell that ensures that this engine runs equitably and sustainably. Now you can see the conceptual relationship. I've really discussed a lot of them. SDG 1, 2, 4, 5, 6, 10, 11, 13. You can take time to pause and read it and form your notes. You can also see here that the health system strengthening, this is the biggest where integrated health system strengthened with PHC foundations and public health orientation. So these are the essential public health functions. And then you see them working together with the primary health care to provide health system strengthening. And together they lead to the SDG 3 universal health coverage, SDG 3 health security, and then you have other health relevance SDGs, which I've mentioned here. All together will provide the overall goal of the SDG 3, which is what? Healthy lives and well-being for all. You can also see here, this is the spoke, the PHC primary health care. You see here the Sustainable Development Goal 3, the universal health, together contribute to the solid foundation here. So you have this as the foundation, this is built on this, and this is the roof that covers both of them. Together, they work as a continuum. So we'll move to number 3. Evidence and case studies. Evidence and case studies. At this point, we want to connect the concepts to the real world practice. We want to see, does primary health care orientation actually make a difference? The answer is yes. And the evidence does prove it. Let's see the empirical evidence. Let's see the empirical evidence. Now, the PHC-oriented system usually produce better health, better equality or equity, and better efficiency. An example is the community health program, the CHPs. You know, a recent review found that CHPs help people access care more easily, cut down costs, and prevent diseases from getting worse, reduce hospital admissions, and even improve social factors that affect health. In short, strong PHC makes communities healthier and more efficient. An example 2 is that of China. China studied its PHC system over 10 years. And then they noticed that when they integrated services, hospitals and clinics that is working together, invested funds smartly and deployed health workers better, the efficiency of the PHC improved. But gains were not equal everywhere. This shows us that context and reforms matter a lot. Even when you have done a lot, you have to make sure that these gains reach the remotest area of any state, any local government. Another example 3, is that of the sub-Saharan Africa and its application of the universal health coverage. Many African countries are actually still struggling with this efficient, use of resources. But those with good governance, higher public health spending, and better education systems have been found to perform better with universal health coverage. This simply means that strong PHC features like equity, local services, and public financing have helped to push PHC forward. Because since they have good governance, higher public health spending, and better education systems, they are seen to perform better with the UHC. And if this is so, it means that a good nature, a good feature of the PHC include equity, local services, and public financing. And the last example, before I move on, is that of the global study that was done within 7 countries. Countries like Cambodia, Ethiopia, and Nepal. Cambodia, Ethiopia, and Nepal. They show that when government expand, community health workers use telehealth, train more staff, and involve communities, health services, and outcomes will improve. I repeat, they discovered in this global study that countries like Cambodia, countries like Ethiopia, and Nepal, they show that when government expand community health workers, when the government use telehealth, when the government train more staff and involve communities, the health services and outcomes actually improve. But there are still gaps that remained. What are those gaps? Shortages of medicines, financing problems, and governance issues. That tells us that even when we have improved, when the services and outcomes have improved, we should look out for these gaps. Medicines, financing problems, and the issue of governance. Now, PHC role in the SDGs. What is the role of the PHC? I've said that before, maternal and child health, which is, of course, a long time. Everybody, you go to any PHC, for that's what probably a lot of people know the PHC for. Over a decade, progress was slow, but it was steady in Nigeria. Like more families using insecticide-treated nets, especially in poorer rural areas. So you have infectious diseases. Some good progress have been made in malaria prevention in Nigeria, although it's uneven. You also have non-communicable disease. In many low and middle income countries, you see that PHC still focuses more on infectious diseases and maternal child health. And that's a gap. Not enough attention is given to non-communicable diseases like diabetes or hypertension, whereas it's supposed to be there. So, we can conclude these empirical evidences by concluding it this way, that when countries prioritize the primary health care, we see better access, fairer systems, and smarter use of resources, but it's not perfect. Some areas thrive, others lag behind. The big lesson is this, that the PHC is powerful, but it works best when supported by good reforms. It works best when supported by proper funding. It works best when supported by strong governance. So when PHC aligns with UHC and the SDGs, communities don't just survive, they thrive. Let's see the second aspect, country and regional cases. We'll pick Nigeria, West Africa, as our country and West Africa as our regional cases. Now, let me begin with the Nigeria Service Delivery and Equity between 2008 and 2018. The scoping review of universal health coverage tracer indicators in Nigeria have shown that while there have been improvements in some service coverage indicators, progress is slow and inequitable. Rural dwellers, those with lower education and poorer socio-economic status, still significantly have less access to the PHCs. And unless pace and focus accelerate, in Nigeria, meeting UHC and SDG targets by 2030 is doubtful. Secondly, primary healthcare quality and best practices in Nigeria. Let's look at that as part of our country and regional cases. A 2024 study surveyed 29 PHC facilities in Nigeria to find best practices and challenges. And I must tell you, they discovered some underserved groups are better reached via the PHC. However, there are still quality gaps remaining, especially in the area of infrastructure, staffing, and drug availability. Another area is the assessment of minimum standards across PHC facilities. Another recent study in Nigeria covering over 25,000 public PHC facilities assessed compliance with revised World Health System, that is in the world, the health system strategy, that is the minimum standards in providing services. It showed that compliance was below 50% across overall facilities, even lower for certain facilities, levels, and even outreach posts. And that is what is happening. The compliance rate in all of these PHCs, many of them is below 50%, especially in the essential areas like infrastructure, staffing, and medicine. Another one is the community ownership and engagement. Remember that we are talking about the country regional cases, and we are looking at Nigeria and West Africa. Under the community ownership and engagement, a 2025 study in Nigeria found that the PHC facilities supported by strong community ownership structures were more functional and efficient. That is, those PHC facilities that the community came together to say, let's support these PHC facilities. Let's own these structures. Let's ensure that we provide them, take care of them, and protect them. Those facilities were found to be more functional and efficient. However, community engagement is patchy, not too in-depth, often depending on local initiative rather than structured policy. Where they could have applied a structured policy, no. And so the engagement is patchy, not deep, not standard. We see that Enugu, that is the southeast of Nigeria, Enugu, there was a study that was conducted there. It showed significant inequilibrium in utilization of the PHC services, where poorest, less educated rural residents used PHC services less. These are practical scenarios, regional cases in the country. Poorest, less educated, they don't even use the PHC. They use it so less. They don't go there. They don't even know the benefit. They don't know what they ought to get because they are not educated, because they are poor. Another one is that of the midwife service scheme. That's a nationwide initiative that was done. This initiative was to deploy skilled midwives to rural PHC facilities like you have in the north to reduce maternal child mortality. And this has seen successes, but also there are challenges. What are these challenges? Funding, delays, infrastructural inadequacy, and this has limited the full potential of the utilization of the deployed skilled midwives. So when they get there, no fund, they sit down. No infrastructure, they cannot carry out their best. Let's now look at other low middle income countries. For example, in Asia Pacific region, effective PHC interventions include non-physician networkers, that is task shifting. You have non-physician networkers also playing one or two roles. They also have integration of services, outreach mobile clinics, and community health worker programs. This intervention improved coverage. It was discovered that it improved coverage, equity, and responsiveness. But there are still challenges. What are the challenges? Quality and sustainability. Why? Because if you notice here, they are using non-physician health workers. a form of task shifting. And probably they are not fully trained. So that quality isn't there. And they couldn't sustain it. In the sub-Saharan Africa, as another example, multiple countries this time, efficiency studies have shown that governance, public health spending, external funding, and prepayment mechanisms matter for UHC achievements. Countries with better health financing and governance perform better. Let's see the other aspect, which is constraints, tensions, and the trade-offs. Here are common constraints and trade-offs that have emerged from empirical work and country case studies. I will discuss them one by one. Before we discuss the 5 lessons learned, let me just quickly talk about these constraints. I think it's very important. I will discuss them. Number 1 is underfunding of the PHCs. Underfunding of the PHCs. Number 2, workforce shortages. Workforce shortages. And then you have maldistribution of these resources. So it's very important that we take note of that. Very, very important. The next one is poor infrastructure supplies and medicines. The next one is inequity, that's inequity in access. And then the next one is governance, accountability, and also management weakness. Governance, accountability, and management weaknesses. We also see competing priorities, and that's where the trade-off comes in. Where resources are limited, sometimes emphasis is placed on tertiary hospital care because of political pressure or visibility rather than the PHC. Donor funding may be embarked. Also, focus on infectious diseases, while the NCDs, the non-communicable diseases, get less attention. And you know what this can lead to? It can lead to imbalanced system, neglected chronic diseases burden, overloading of the hospitals, undermining health system resilience. And then you have the SDG targets across disease, which, disease types may now lag. We also have the sustainable transition from donor dependence. All these are major, constraints. You will find the table at the end of this particular section, and you can take your time to study the constraints and tensions, the description and the evidence, and the implication to the public healthcare, universal health coverage, and the SDG alignment. Now let us see the lessons learned. There are 5. There are 5 of them. What are the 5 lessons? Number 1, build the PHC foundation. Because if you don't have the basics, that is trained health workers, good infrastructure, steady medicine supply, reliable funding, then even the most fancy or popular health programs will collapse. Now think of it, building a house without a strong foundation. That house won't stand. Another lesson, lesson 2, is that equity is non-negotiable. Equity is non-negotiable. If the PHC must deliberately focus, the PHC must deliberately, focus on those poor people, underserved people, the poor, rural populations, and those with less education. If we don't, inequality will grow. And the rich get healthier while the poor are left behind. Lesson 3, we'll see that governance and community involvement matter. So let's not only think about money. It's not only about money. How health facilities are managed is important. How communities are included in decisions are important. And how well systems are supervised and held accountable. These things are just as important as funding. Lesson 4. Balance the health priorities. Historically, PHC has been strongest in maternal and child health and infectious disease, like malaria or HIV. But non-communicable diseases like diabetes, hypertension, and cancer are rising fast. We need a PHC strategy that will address both the communicable diseases and the non-communicable diseases. Because you find the PHCs developing themselves, growing better in maternal and child health, infectious diseases, malaria, and or HIV. But you don't find them taking care of people who are diabetic. They have to now start traveling to the tertiary institutions, healthcare centers, those with hypertension, those with cancer. This is rising fast, and we need a PHC strategy that will help the PHC to take care of both. You have diabetes, you just go to the primary health care, they will manage it. You don't need to start coming, but that's what is obtainable today. Because you get to the primary care and say, we don't handle this one here, we don't have a doctor. Then what do you have? Even the resident health care officer, in form of task shifting, can be trained. You can even have qualified doctors, nurses, scientists posted from time to time on rotation to the primary health care centers. And lesson 5, think long term and across sectors. Think long term and across sectors. We mean health system work best when they are sustainable, meaning countries fund them locally, link them with other sectors like education, sanitation, and water, and make them resilient against shocks like pandemics. When you take care of the PHC, because you have a long-term goal, and you ensure that it goes, you fund them locally, you get them from other sectors like education, sanitation, and water, ensure that it is what made resilient against shocks like pandemics. And finally, measure what matters. We can't improve what we don't measure. So if you can't measure what is done in the PHC, how can you improve it? So you need clear indicators. You set a minimum standard, a minimum quality standard, and regular monitoring performance. Because when you do that in the PHCs, it will help performance, and it will help us to be able to track this performance and know what's the level of progress. It will also help to fix the bottlenecks, because we will know where the bottlenecks are, and then we can improve policies. And so in summary, we must invest in the basics. We must protect the poor. If we want the PHC to truly drive better health outcomes, we must balance our priorities. We must think long term and measure consistently. That's the formula for strong, sustainable, and equitable health systems. So these are the constraints, tension, and trade-offs. So you can take time to study it, pause, and then study it. Constraint and tension, the description and the evidence, and then you can see the implication for the primary health care, universal health coverage, and the SDG alignment. You can see the second part here, and take time to study it. I'm sure that you will understand it. It's as simple as you can imagine, and detailed. Okay, so these are the references. We move to the fourth aspect, which is strategic approaches, making PHC and SDG works. Strategic approaches, making PHC and SDG work. Now, what are these strategic approaches and how to align this PHC with SDG goals in the real life? So let's get practical now. We have talked about concepts. We have also talked about evidence and lessons. But how do we actually do this? How do we strengthen primary health care so it pushes forward the UHC and the Sustainable Development Goals? I'll try to break it down into two big strategies. Number one, strengthen the PH systems. And what does this mean? As you can see up there, this is about fixing what's inside the health system. Things like building a strong health workforce, improving facilities, making sure medicines and supplies are always available, and securing, steady financing, basically making PHC reliable and high quality so that people, trust and can use it. You also have the multi-sectoral, because I told you it's in two areas: multi-sectoral action and policy integration. Apart from strengthening the PHC system in real life to make it work, you also need the multi-sectoral action. And health doesn't exist in isolation. Clearly, we all know that. So to make PHC work, we need education, we need clean water, we need sanitation, we need good roads, even strong economic policies. So PHC has to connect with other sectors, because progress in health support, progress in other SDGs work hand in hand, and they are vice versa. So when you have progress in health, it will support progress in other SDGs. They work together. So ensure that the both of them, both the health support, the health itself is making progress, and then the SDGs in turn will also make progress. If you want PHC to drive the UHC and the SDGs, then you need two hands working together. That's what we see here. So one hand strengthens the health system itself, and the other hand links health to other sectors. So when both hands move in synchronization, the system is stronger, more equitable, and sustainable. And so now I want to dig into 4.1, which is strengthening the PHC system. I just gave you an introduction. Now let's look at it properly. Let's dive into how we can actually strengthen primary healthcare system. When we say strengthen, we are talking about making PHC more accessible, fair, reliable, and high quality. To do that, there are three main areas we need to work on. Number one, the health workforce training and development. Number two, infrastructure, supplies, and health information system. And number three, integrated service delivery model. For the first one, the PHC is only as strong as the people who run it. So we need better training, both before and during service. And this will include skills for dealing with community issues, equity, and leadership. How about that of the task shifting, where some responsibilities are moved from doctors to trained community health workers so services reach more people? And then also retention strategies like incentives and supervision, so that health workers, they can be motivated, especially when you send them to the rural areas. For example, in Nigeria, the government trained 120,000 frontline workers to serve in both 37,000 PHC facilities in Kaduna and Kano State. Task shifting to community health extension workers was improved. And since it got improved, it further improved access and quality of care. So you see the beauty of improving task shifting to community health extension workers. In turn, has improved the access and quality of care. In the area of infrastructure, supplies, and health information system, we see that for PHC to work, clinics must have the basics. Clinics must have reliable water, power, space, and communication. They must have essential medicines, vaccines, and diagnostics, and equipment. So strong health information systems, accurate, timely data must be available to be able to guide their decisions. And now you have digital tools like telehealth and mobile apps to reach underserved areas. For example, during the COVID-19, Strengthening the health information system and improving infrastructures was one of the key global strategies for keeping the PHC running. Some countries like Chile built what we call the Integrated Citizen Health Information System to improve referrals and to track population better, than the normal as it used to be before. So they could track the population of health better. They could know, okay, this population has issues because reports are coming from there, people are getting ill from there, and they could look at the heat map. Number 3 is the integrated service delivery model. Instead of sending patients to multiple clinics, the PHC can become a one-stop shop. And that means offering services for different needs like HIV, TB, tuberculosis, maternal care, non-communicable diseases, and mental health, all of them in one place. And having strong referral systems to secondary and tertiary care when added. Shifting from episodic, emergency-only care to continuous. People-centered care throughout life. All these things, when integrated, will improve the service delivery model. For example, in Nigeria, Vietnam, and Eswatini, HIV services were successfully integrated with PHC in community-led clinics. Patients received holistic care in one place, leading to better access and outcomes. Similarly, integrating diabetes and hypertension care into the PHC is showing great promise in many middle-income countries. A quick recap. We have seen under the strengthening of the PHC system that to strengthen the PHC, you need a well-trained, motivated health workforce, a stronger infrastructure supplies, an information system, and integrated people-centered service delivery model. When these three come together, the PHC becomes very resilient, trusted, and effective. And the real foundation of UHC and SDGs will be in place. We look at the second aspect, multi-sectoral action and policy integration. When we talk about multi-sectoral action and policy integration, what we are saying is this, that health is not only created inside hospitals or clinics. Most of the things that we are talking about affect people's health. For example, clean water, food, housing, education, transport, and even the environment actually sit outside the health sector. So if we want PHC or primary health care to really work and to achieve the SDGs, especially SDG 3 on health, then different sectors have to work together. So let me walk you through, 3 big strategies. Number 1, health in all policies. That is the HIAP. Health in all policies. This means that whenever government makes a policy, whether in transport or agriculture, housing or urban planning, they should always ask, how will this affect people's health? Because some countries set up intersectoral committees or special units to make sure of this, to make sure that it's affecting, they find out how it affects people's health and it is ensured that it is serving its purpose. For example, in Norway, municipalities have what we call public health coordinators who bring health into local planning. Where these coordinators had authority, they actually reduce health inequalities because they bring in this, health planning into the local, they integrate it into the local planning. So these coordinators, wherever they are, they found out that they have actually reduced health inequalities. Number 2 is collaboration with non-health sectors, health workers, can't do it alone. Collaboration with non-health sectors, health workers can't do it alone. They need partnership. This partnership is key. For example, water and sanitation team prevent waterborne diseases. Can you imagine that? Education improves health literacy and supports school health programs. Agriculture fights malnutrition and hunger. Urban planning ensures safe housing, better transport, and less pollution. Environment and climate sectors help reduce risk from air pollution, flooding, and climate change. In Chile, Costa Rica, we see that the primary health care centers work hand in hand with local governments to align municipal planning with health needs. Let's see number 3 there. Governance and institution coordination. This is about how all the players are organized and held accountable. There should be clear roles at national, state, and community levels. Local governments and civil society should also sit at the decision-making table. Budgets that are being designed must align across ministries so that health is not left out. You don't finish it and remember that you didn't add health to it, or that you added health but you didn't get the full information needed before carrying out that decision. WHO found that countries with strong governance and leadership in primary health care were more resilient. So what's the take home here? Health outcomes are not just about doctors and nurses. They depend on every sector of the society. The primary health care is like the engine, but other sectors provide the fuel. Without integration, the engine cannot run well. So, what is the implication? What are the implications? Number 1, context matters. Context matters. When we say context matters, we mean what works in one place may not work in another place. For example, a program that succeeds in a city with good funding might not work in the same way in a rural village. And so, you always have to consider the local culture, resources, and environment. Number 2, you have the sustainability and financing. Health programs are not one-time projects. No. You need money not just to start them, but also to keep them running, like maintaining equipment, training staff regularly, making sure medicines and supplies don't run out, and supervising the workers that have been posted there. Number 3 is equity and inclusion. We can't just focus on the on the easy to reach people. We can't just focus on them. There are those that are not easy to reach, that you can't even drive to those places. You walk to those places. In fact, you can't even walk. You may need to take the donkey, animals, to be able to transport yourself there. The quality must be, of good care. These policies must include everyone, especially the poor, marginalized, and vulnerable groups. This community involvement is also very important because it will make programs outcome successful. Number 4 is the quality, not just coverage. Quality, not just coverage. Remember, we're talking on the implications. The implications and considerations when you look at the multisectoral action. Number 4, it will give you quality, not just coverage, because it's not enough to expand services. We have to look at the quality as well. If care is unsafe or staff are poorly trained, people will lose trust and won't use the services. This can stop us from reaching health goals. Number 5 is monitoring, evaluation, and learning. We need to collect data, analyze it, and use it to improve policies. Think of it like a feedback system. You try, then you check your results and adjust for better outcome. Very simple. You try. When you are done, you check for results. And when you are done checking for the results, you see the outcome, then you adjust for better outcomes. Number 6, synergies and trade-offs. That's part of the consequences of the multisectoral action. Synergies and trade-offs. Health policies sometimes require choosing between options. For example, do we spend more money on primary health care or on big hospitals? Do we focus on one disease or strengthen the whole system? These are tough but necessary trade-offs. In fact, or in conclusion, good health policies must fit the local context. It must be properly funded. It must include everyone. It must maintain quality. It must be data-driven and balance resources wisely. We look at the third one, which is community and citizen empowerment as part of the strategic approach if you want to make the PAC and the SDGs to work. So now let's talk about why empowering communities and citizens is so important. You know, this is not just a kind of bonus or many talks, no. It's at the very heart of making primary health care sustainable, fair, and responsive to real needs. When people are empowered, they trust the system more. Services are more relevant, and uptake of health services will improve. It also helps address the wider social factors that influence health. Number 1, health literacy, participation, and accountability. That's how we are looking at how communities and citizens can be empowered now. Communities must understand their health and have a voice in decision making. This means that you run health campaigns in local languages through channels people actually use. It also means that you are going to hold community meetings, facilitate committees or citizen panels so that people can shape decisions. Let there be committees, set up panels of citizens so that they can also have input. And also creating feedback systems like suggestion boxes here and there, carry out audit of the PHC, or community scorecards. Ask the community, come and tell us what you think. Carrying out a survey. Also, you can provide this health literacy, participation, and accountability by training and involving local leaders. So they act as bridges between communities and the health systems. For example, in Nigeria, communities with stronger ownership and engagement had better functioning PHC facilities, more immunization, more antenatal care, and better overall outcomes. Similarly, WHO reports how village leaders in Chile and Lao PDR could develop health plans with providers. They came together in Chile. They were able to develop health plans because they co-opted themselves alongside with the providers and they worked together. Let's see number 2, co-design of services and community health workers. You know, communities shouldn't just be recipients of care. They should also help design the services. Yes. And this will improve cultural acceptability and reduce barriers. And how can you do that? Include community members when planning what services to offer and where you want to offer them. How can you achieve that? Strengthen community health workers as educators, as connectors, and as service providers. To achieve that, you must ensure that community health workers get proper training, get proper supervision, and provide incentives so that they are motivated, they stay motivated. Encourage collaboration between these community health workers. Let them work among themselves. Health facilities. Let those health facilities collaborate. And let this community form groups so that they can monitor their main localities and they can collaborate with information. In Nigeria, World Development Committees supported the PHC by giving feedback, by coordinating with staff, and mobilizing resources. And we've seen that globally PHC frameworks now recognize empowered people and communities as a core component of successful health system. So take away the community, the PHC will suffer. The PHC will do well with the help of the community when the citizens are empowered. Let's see the next one, social mobilization, as part of ensuring community and citizen empowerment. Finally, you see that communities themselves can now drive change through social mobilization. And how do you do that? You mobilize women groups, youth groups, religious bodies for health promotion and prevention. You can also use peer educators and health events to spread messages. You can use peer educators when you train them, bring them together. You can also build on existing cultural practices that they've been doing before now that is good. And you can network to spread healthy behavior. Network from one locality to another, the news will get to the remotest part faster. And you can strengthen social accountability with scorecards and public reforms. In Nigeria, communities enforced sanitation and supported facility maintenance through their own initiatives. Reviews show that social mobilization, you see, often leads to real behavior change and measurable health outcomes. In fact, empowerment means giving people knowledge, giving people a voice, giving people roles to play. So when communities co-own health systems, PHC becomes more sustainable, trusted, and effective. Now we'll look at 4.4, financing and resources protect PHC in national budgets. Financing and resource mobilization. That's what it means in a nutshell. The next big question is money, because without proper financing, PHC cannot align with universal health coverage and the sustainable development goals. So how do we fund it sustainably and how do we fund it fairly? Number one, allocating domestic resources. You see, governments need to commit more budget to the primary health care, and that includes increasing the PHC's share in the national, in the, in the health budget. When you increase the PHC's share. Number two, including PHCs explicitly in national health plans and laws. When you include the PHC explicitly, when you want to make laws, let the PHC be involved. Ensuring predictable funding for salaries. Okay, this is what we are going to spend. We make that up. Not that in the middle of the year, you find out that the money that was budgeted wasn't enough to take care of salaries. No. You should ensure predictable funding for salaries, medicines, and maintenance, and reducing over-reliance on donor funding and planning for transitions. Every time we are depending on donors, look at the recent happening with the United States pulling off. That tells you the danger of over-reliance on donor funding. There's a need to plan for transition. What about if the donor no longer comes like what is happening now? Number two, to be able to ensure proper finance and resource mobilization, you should have mixed financial models. One single model really works. Mixing them will help. Mixing such like social and mandatory health insurance, where they are possible, you mix them. Community-based micro-insurance for formal sectors, you can do that. Public-private partnerships and donor-government pooling, they come together, provide what we call the basket funding. And then you have the performance-based incentives that are tied to PHC goals. If you achieve this, this and this will be given. An example is Zamfara State in Nigeria, where basket funds combine government, donor, and immunization funds to support the PHC. In China, the subsidies plus PHC funds supported staff incentives and infrastructure. You see that? Combining, these financial pools together helps to achieve more. Number three, efficiency, prioritization, and sustainability. It's not just about raising funds, but using them wisely. And how can you do that? How can you do that? Prioritize essential PHC services: preventive, promotive, basic, curative. All those ones that give the biggest returns. Prioritize because you don't have enough money. The next one, you cut waste so that you can be efficient in prioritizing. Cut waste, fix supply chains, reduce duplication where you are duplicating efforts. No. Prevent stock outs so that you don't get to the middle of treatment, you find out that the drug has finished. Prevent it. Plan for sustainability, that is maintenance, staff retention, equipment replacement. Explore innovative financing. Think out of the box, like sin taxes, earmarked taxes, or public-private partnerships. For example, China reforms didn't just raise money, they regulated how funds were spent. That's a good reform. Not just about raising money, but how do we spend this money? Guaranteed minimum salaries, and it motivated their staff. Nigeria's domestic financing literature also emphasizes predictable basket funding to reduce fragmentation. And therefore, in summary, before we go to 4.5, financing PHC requires strong government commitment, smart use of mixed models, efficiency in spending, and sustainable planning. Without this, achieving UHC and SDGs will remain a challenge. Community empowerment gives PHC its heart, while financing gives it its backbone. Without both, no heart, no backbone, the system cannot stand strong. So the PHC gives, community empowerment gives the PHC that heart, while the financing gives it backbone. So that's why the community is very important, and the financing must not stop, so that the system can stand strong. Let's look at the next one: monitoring and feedback. Monitoring and feedback. What are the metrics? Now, here is a big question. How do we know if PHC strategies are actually working? The answer is monitoring, using of metrics, and feedback. It's not just about collecting numbers. It's about using those numbers to be able to adapt, improve, and hold a system accountable. What are those indicators that link the PHC, UHC, and the SDGs? What are those indicators? We can't just pick random indicators. We need the right ones. Number one, use tracer indicators. They measure service coverage, financial protection, quality, equity, and resilience. Number two, track across all stages. Track across all stages. These inputs like staff, medicines, processes, outputs, outcomes, and long-term impact. Track it across all the stages. How is it going? Check it. Number three, disaggregate data by location, by gender, or income, so that we don't miss inequalities, so that we don't miss it. Disintegrate it. Check it by location. Is it doing well there? Check it by gender. What is the data there? Check it by income, so that in each of these areas, you don't lump them up. You get information. And finally, when we talk about, random indicators, proper indicators, add PHC specific indicators like how many communities like health workers are available. How many community health workers are available? Whether essential medicines are in stock. Check. And how ready facilities are to deliver care. For example, the WHO Primary Health Care Measurement Framework tracks three main components: integrated services, multi-sectoral action, and empowered communities. The UHC service coverage index, that is the SDG 3.8.1, uses 14 tracer indicators. And these tracer indicators, they actually range from maternal and child health to non-communicable diseases. And so it is important that you take note of this WHO PHC measurement framework. It does a wonderful work by tracking three main components. So let's move to the number 2, using data and feedback loops. Data is useless If it's just in a report, it should guide actions. Otherwise, it's useless, just in a report. And so how do we use it? Collect data regularly at both facility and community levels. Collect it. Review those indicators monthly or quarterly. Review them. Check them after you've collected them. Review them. Number 3, use digital tools to make data available faster. Number 4, conduct patient satisfaction surveys. Hear from the patients. They are your best indicator to be able to give you feedback loops and facility readiness checks to tell you, oh, okay, this facility I think is doing well. I think their services is good. Oh, this services is bad. You now know what to do in that particular area. Most importantly, you need to build systems that allow managers and policymakers to adapt. Let your managers think out of the box, so that when data shows gaps, they can think of ways to be able to survive, take care of those gaps, and surmount those challenges. In China, when they reformed the PHC financing, data showed improved coverage and service use in rural areas. This evidence justified scaling up reforms. Similarly, WHO framework stressed things like complete facility, reporting, and digital health records as part of effective monitoring. So this is key. This is very important. Look at the third aspect, accountability and reporting. Accountability and reporting. Monitoring only works if there's accountability. So why monitor something that you are not, people won't be accountable for? So it only works if there is accountability. Government should hold national health reviews that report on UHC and the SDG progress. And data should be shared publicly, not hidden. Let people read it and confirm if it is true or not. Communities should also be involved through community scorecards, surveys. They should give you public reviews, because you may not see it entirely from the inside. A lot of them from the outside will see it properly. In some countries, reporting is tied to funding, which keeps health managers serious about results. So internationally, countries also report progress through voluntary SDG reviews. For example, WHO publishes annual reports on UHC and the SDG progress, tracking service coverage and financial protection. In Portugal, you have the PHC family health units were monitored. These units were monitored using performance indicators that are aligned with the SDG 3. And this helped track how PHC was pushing the SDG targets. And if we have the same in this country, it will go a long way. Let the reports be published. Let people read it. Let people know what is available, what is working, what is not working, and they can suggest what to do. I need to emphasize this. Number 1, community empowerment is not just consultation. It's real ownership and power sharing matter. Number 2, it's important that we look at the issue of financing. It must be sustainable. It must be sustainable, and it must be fair. You need to understand trade-offs between taxation, insurance, donor, and community funding. Number 3, you should, understand that monitoring is only useful if it drives change, because data without feedback loops is a wasted effort. If you get data, you don't get feedback. People don't tell you what they think. It's all you think, is all you think you know. You think it's all you see? No. Number 4, context matters. Nigeria and China have shown useful lessons, but every country needs local adaptation. We've also seen that metrics must go beyond coverage, include equity and resilience, like whether PHC can still deliver during shocks such as pandemics. So the take-home point is this: under the strategic approaches making PHC and SDGs work, good monitoring is like a mirror. It shows us where we stand, but a mirror is useless if we don't adjust what we see. So you look at the mirror, you see that there's a powder on a patch somewhere on your face and it looks ugly. Good, the mirror has just done its job, but you still go out like that. What does that mean? You looking at the mirror is useless if you don't adjust to go and clean it up or adjust the powder intensity to make it look good. PHC systems must not only measure, but it should adapt. Otherwise, the numbers mean nothing. I'm sure you have learned a lot from these aspects. Let's move to the final part, the summary and takeaways. As a recap, what PHC really is. It's not just a small clinic at the corner. It is the foundation of the whole health system. The first contact between people and health services. So it covers everything from promotion and prevention to treatment, rehabilitation and palliative care, while also tackling the social factors that shape health like water, housing and education. Number 2, the relationship of the PHC to UHC to SDG as the connection. You can simply see it this way. Simple. PHC is the engine that delivers essential health services. UHC is the gearbox, because that is the vehicle that will drive the engine. So it ensures that financing, coverage, and system design to make PHC available for everyone. SDGs are the road map. That's the global goals that we are driving to, we are reaching, we are trying to reach. It's important that you understand that, because without alignment, you won't get to the destination. So the Astana Declaration of 2018 made this crystal clear that PHC is the most effective and inclusive way to achieve health for all. So don't ever forget this. Think of PHC as the engine, UHC as the gearbox, and SDGs as the roadmap. Without all three working together, the car won't move in the right direction. Lesson number 3, why the continuum matters. Why is this discussion as a system, not in isols, not in silos, not in separation? Why is it that we must see it as a continuum? It will help us to see where gaps are. For example, if you have a good PHC services but no financing, people won't use them. If you have strong financing but weak PHC, money gets wasted on big hospitals while communities stay underserved. So research shows that the same pattern again and again has been occurring. So with this research evidence, success depends on getting this alignment right. So with this information that you have received today, you now know that they are connected. One is the engine, one is the gearbox, and the other is the destination. And they must all work together. Number 4, we see the enablers. What makes it work? Number 1, there are 6 big boosters that make it work. And what are they? Political commitments, sustainable financing, strong workforce, that is, when you train, you do task sharing, you provide incentives, rural support. Number 4 is functional PHC platforms, where you provide infrastructure, medicines, diagnostics, and referral systems and digital tools so that they can work well. Number 5, multi-sectoral governance, teamwork with water sector, education sector, nutrition, housing, civil society. Number 6, community empowerment, where you co-design with community health workers, accountability system is ensured. Once you do this, I tell you, you have provided an enabling environment so that it will work. You must understand the barriers. What are those things that block progress? There are common roadblocks we see in many countries. For example, underinvestment and fragmented funding. Number 2, health workforce shortages, especially in rural areas. Number 3, poor coordination with other sectors like sanitation or transport. Number 4, weak governance, poor data use, low community voice. And number 5, politicians love shiny hospitals, but they ignore the PHC. They love the big hospitals, but they ignore that small 1 or 2, 3 rooms, small building in the local areas. Even though PHC gives more value, they still spend more money in the general hospitals. And that's the problem that we'll have. So as a recap, a quick checklist for policymakers and future public professionals. If you had to advise a district health manager tomorrow, then you have to listen to these 3 simple actions that you must take. Number 1, define and cost an essential PHC package that will fit local needs and the SDG targets. That's what you need. Make it local. Define it and make the cost an essential part of the PHC package so that it will fit your local needs. Number 2, secure predictable funding for salaries, medicines, and basic transport. And add some financial protection for the pregnant women and children, because they are among the most vulnerable. Number 3, set up community governance groups. This is how you provide a quick checklist for policymakers. This community governance group include the facility committees, community health workers links, and monthly data reviews that track equity. Very important. So these are the reflection questions that you should go home with as we conclude. These are the questions you should go home with. Where does PHC investment give the biggest gains in your country? Is it maternal health, infectious disease, or non-communicable disease? How should governments balance PHC and tertiary care when budgets are tight? What is the best way to finance the PHC in an informal economy? All these I have talked about them. So what exact role should community health workers play in helping to achieve the SDGs? Which governance models work best for cross-sector action? Which governance models? So what indicators would show if PHC is really driving the SDG 3 in year 1, 3, and 5? What indicators would show if the PHC is really driving the SDG 3 in year 1, year 3, and year 5? So these are the reflection questions, and these are great for essays, group work, or policy debates. In conclusion, strengthening PHC is not just a health project, it's a political, financial, and social project. When PHC, UHC, and the SDGs align, that's when we really move closer to health for all. You can simply put it this way. Strengthening PHC is not just technical, it is political. So when we align people-centered PHC, smart financing through UHC, and cross-sector action, we stand the best chance of delivering the SDG promise of health for all. It's a little building in a little corner in a remote village, but it is the most important, and it should be able to take care of everyone and without making anyone go broke after treatments. I want to thank you for this time with me. I've taken you through this lecture, and I know that you have learned a lot through this lecture. And no doubt, you may have one or two questions. Feel free, under this video, you can ask your questions. Please make comments. And if you enjoyed this lecture and you like to listen to more, then you can go ahead and follow me on my YouTube page channel. But please make sure you like the video and share it to your friends. And don't forget to subscribe. Till I come your way another time, thank you for listening, and I wish you the best as you continue to learn and practice. Once again, my name is Dr. Isagbonyi Henry. Thank you very much.